I'm Daniel Berman from Cedars Sinai Medical Center, where I'm the Director of Cardiac Imaging. I'm here at the 19th Annual World Congress of Cardiology put on by Dr. Asher Kimchi. And I want to say just from the outset that this is one of the most unusual cardiology meetings that I go to. It is so enjoyable with people from more than 50 countries around the world, with a truly international interchange of ideas, information, and ways of treatment of patients that provide something no other meeting does. My talk at this year's meeting dealt with value-based non-invasive imaging. You know, all of the tests we have are extremely accurate for prognostic assessment or for diagnostic assessment, but they cost a lot of money. Going forward, we're going to have to prove value. We either have to improve outcomes, which might be quality of life or cardiac events, or we have to reduce costs. That ratio has to improve in order for us to provide value. In the new environment, in the United States as well as worldwide, in order for testing to be utilized, it has to show value. I illustrated this in my talk in 3 different areas of coronary disease: prevention, diagnosis, and then management of patients with known disease or heart failure. In the prevention area, stress imaging is probably not going to be the test of choice. If we do any testing, I think it's likely to be atherosclerosis imaging with the coronary artery calcium scan as the best example. This test is likely to improve outcomes over time with only a slight increase in costs, and I think will provide value. In the patient with chest pain syndromes, in the acute coronary setting, multiple randomized trials have now demonstrated that coronary CT angiography, compared to standard testing, reduces the length of stay in the emergency department and increases the direct discharge rate. We're going to find that that test provides value to a healthcare organization. In the stable coronary disease patients, in those where we think the likelihood of disease is rather low, coronary CT angiography, with its extremely high sensitivity and specificity, becomes, I believe it's going to show, a valuable test. For example, we already know that many of the patients presenting with chronic chest pain and suspected coronary disease have completely normal coronary angiograms by coronary CTA. When they do, the warranty period appears to be 7 years, and we don't even have long-term data to follow up these patients with this new methodology. The ability to define completely normal arteries is going to be a very powerful component of CT. CT also has the potential to characterize the amount of coronary disease a patient has with chronic coronary disease and help make decisions about catheterization. For the patients with known disease or with a very high likelihood of coronary disease, stress imaging is a very powerful tool and will continue to be a powerful tool. Also, there are certain patients that can't have CT coronary angiography, such as those with renal failure or extensive coronary artery calcification where CT can't be used. Some patients cannot exercise, and their pharmacologic stress testing becomes important. But we know now from the literature and multiple registries that the amount of ischemia appears to predict who would benefit from revascularization in this stable disease setting. But whether that's true in randomized clinical trials hasn't been shown yet, and that's why the ischemia trial currently being conducted is so important, this worldwide trial that we hope all centers around the world, or many centers, will become involved in. And then finally, if we look at heart failure, coronary CT angiography could tell us that it's of non-ischemic etiology. But further management of most patients with heart failure, if it uses imaging, it will be echocardiography, as was covered in a separate talk. Or potentially it could be using the techniques of PET scanning for viability or MRI for assessment of the etiology of heart failure as well as viability. Overall, if a test is going to provide value, any test, it's got to change patients' treatment. So our results of testing by themselves won't provide value. The value is only going to be provided if the test results alter patient management. And that communication of the need to alter management and how to alter it becomes a challenge for the people who are involved in cardiac imaging.